Again, a very good day, my dear postgraduate students. Welcome to the short class on bone marrow aspiration or biopsy and the diagnosis it delivers. Class number 12 for postgraduates. A 32-year-old male presents with this clinical picture at the medical OP. A complete hemogram, including the peripheral smear, was asked. What are your comments? So this is a picture of a patient. I find that there are multiple small to moderately large blotchy areas of hemorrhage. Now at this point, I would like you people to kindly read up what is purpura, what is petechiae, what is ecchymosis, and what is frank bleeding. These are the different entities you people will definitely be asked in the viva and thrombosis, in the bleeding disorders, so on and so forth in your examinations. That having been said, I'll go to it. I hope you people, in the context of bone marrow aspiration, in the background of hematology, you are able to make a diagnosis. Anyway, the hemogram was asked for and the peripheral smear comes to you. What is your opinion? Always in a peripheral smear, there are only two elements that we can comment upon. One will be the WBC. Two will be the platelets. Regarding the RBC, I cannot say what million count it is. But then obviously there is a leukopenia with a simple neutrophil over here and platelets are markedly reduced. They have been markedly reduced and I do not find any clumping here. So my diagnosis can definitely be a thrombocytopenia. And this particular patient would have been a case of 32 years old and he has come to the medical OP. So it is not an emergency. He would have been visiting that OP quite recurrently. The bone marrow biopsy, it showed this picture. So in this bone marrow, what are the cells I am seeing? Always remember the largest cell that you people can see in a bone marrow aspiration will be the megakaryocyte. So obviously you find that there are the other cells and in a biopsy, I cannot appreciate and identify the other cells. As I had mentioned earlier, identify a cell by the company it keeps. So there are multiple cells which are huge and some of which are lobulated, some of which are having a circular nucleus. Hypolobation is present. So there is a crowding of the nucleus. Otherwise, the marrow appears fairly cellular. Between erythropoiesis and leukopoiesis, an aspiration is better. A slide for diagnosis. Again, I find that there is a normo or a mild hypocellularity over here. These cells are probably the erythroid precursors, but because there are too many of them similar and then they are together. And there are some larger cells also. But then these larger cells attract my attention. I find that they are huge. They are having a dumbbell-shaped nucleus with an involution, or sometimes they are just ovoid in appearance. And compare this with the normal bone marrow that I'm showing here. It is about 70 to 80% cellularity, in which I'm finding a single, if this were also to be construed, two. But here, within a short number of cells, I find that too many of them are megakaryocytes. Obviously, there is an increase in the megakaryocytes. What they are, we shall be seeing. Two things we have seen. The patient has got bleeding disorders, there is a thrombocytopenia, and the bone marrow is showing increased amount of megakaryopoiesis. The diagnosis obviously will have to be ITP. So this is the maturation of the platelets. So there is a hemocytoblast or a committed stem cell. And then there is a myeloid and a common precursor that is over there. This will lead to not only the myeloid series, but also the megakaryocytic series. This is common. That is why in a case of a chronic myeloid leukemia, not only are the leukocytes increased, but also the megakaryocytes. There is a megakaryoblast, blast cells round, nucleoli are there, circular lumen. And then there is an incomplete budding in a pro-megakaryocyte. And finally, you find that there is a budding nucleus. Also, you find that there can be pseudopod-like extensions, which will be chipped off And these are the platelets that you get in the peripheral blood. This is how it happens. This is a megakaryocyte, this is a capillary or a sinusoidal space, and these are the extensions which are being chipped off, and you get as platelets in the peripheral blood. Normally, this entire maturation, it takes about 8 to 12 days. In a case of ITP, what will happen is there is an increase in the number of megakaryocytes. Shift to left. There can be more pro-megakaryocytes which are present. The cells are more rounded, as in this case. They are more rounded. There are no blebs in the cytoplasm. Crowding of the cells will be present. And these cells are obviously smaller. You find that the blast is smaller than the megakaryocyte. Please remember. The megakaryoblast is smaller than the megakaryocyte, whereas a myeloblast will be larger than a leukocyte. And when we do report, these are the subheadings that are to be followed. The cellularity, whether all the lineages are present, erythropoiesis, leukopoiesis, etc. And specifically describe the megakaryocytes. So they are greater in number, there is a crowding, there is a nuclear abnormality, no budding is seen, etc. And this is the pathogenesis of the ITP from my book, namely 1 page. I would like you people to kindly follow this up. So this is what you are seeing. So it is an idiopathic autoimmunity. There will be the antiplatelet antibodies. And because of these antibodies, you find that there is an opsonization of the platelets leading to their destruction. Also, there can be a suppression of the megakaryocytes leading to a thrombocytopenia. And also there is a decrease in the lifespan of the RBCs, which can lead to a decrease. Acute will be for a period of about 3 months, whereas chronic can be for more than 3 months. And these are the things. Petty K means less than 2 millimeters, purpura 2 to 10 millimeters, and ecchymosis are large and blotchy, more than 10 millimeters. And look at the wonderful range in which megakaryocytes can be seen. It can be in hemolytic anemia. It can be in a case of ITP, as in these two cases. Sometimes it can be because of chronic myeloid leukemia, where there is a dwarf megakaryocyte which is seen, or it can be in polycythemia vera. Again, there is an increase. It is a hemolytic anemia where there is platelet increase. Pleomorphic in a case of PMF. Also, you find that there can be the giant megakaryocyte in essential thrombocythemia and an acute megakaryocytic leukemia. PMS, primary myelofibrosis. So these are the various conditions in which people can see. It is a summary. I would like you people to kindly follow this text. Tusantak, which means thank you. Please find out the language.